Okay, yesterday we showed you this rhythm and talked about a patient that was extremely fatigued in this rhythm with this blood pressure, these vital signs. And we asked you what you should do. Well, let's talk about it. Okay, so when it comes to a third degree block, which this rhythm is, what it means is that we have the P waves that are still heading towards the AV node because they're all upright, they're all in basically happening on a pretty consistent basis, but there's a disconnect between basically the atriums for the atrial contraction because we got good P waves, and a disconnect between that and the ventricles because the ventricles are still contracting, we still have narrow QRSs, but they are not correlated with the P waves, and that is your very kind of classic presentation of third degree block. Now, as far as the treatment goes, what should we do for this patient? Well, we gave you a very fatigued, very sick patient with a map that is declining, and so this patient is pretty sick and needs intervention, and so you basically would be starting down the route of potentially atropine, but really the fact that the atropine doesn't typically work in third degree block. You might have a higher success rate because the QRSs are narrow, meaning that they're taking the electrical pathways here, but the likelihood of it working is pretty low. Next thing you'd be looking at potentially a small fluid bolus to see if you can improve the map, and then you could be looking down the line of using something like epinephrine in order to improve contractility and cardiac output, and then ultimately you'd be looking at pacing because as far as ACLS goes, this patient is unstable and that pacing is indicated. And so those kind of the routes that you're going, most likely going down the route of pacing.